It's important to know that I am a full-time employee of ViiV Healthcare. However, I hope to be as fair balanced as possible, and I will not say anything negative about any of our competitors' products. I think it's clear that with the advancements in antiretroviral therapy, certainly over the last 20 years, this has had significant impacts in our ability to help our patients and especially transform and really make the landscape different for HIV. This includes reducing AIDS-related morbidity and mortality, HIV-related morbidity and mortality. The important aspect of when there is access to the best medicines, and I do understand the issue of access here in China, as I do in many other countries, that assuming you have access to the best medications, and assuming that the patients, even if do not have the best, latest medications, if the patient takes the medications, viral replication will be significantly suppressed for a long time, and I think importantly, this is the best prevention for HIV transmission that we have at the current time. The other aspect with the advancement of antiretroviral therapy is convenience of the regimens that we ask our patients to take. This slide shows the currently available antiretroviral medications in 2016. We have a number from 6 classes, and on the horizon there will certainly be other classes and other targets for medicines. And again, I want to emphasize that these are the currently available ones globally, but not in all countries and in all regions. I think we all know, because the elusive eradication or cure, which my good friend Bonaventura Clotet will talk about shortly, we have to be able to have medicines that our patients can tolerate. And therefore, even though we have to assume that any medicines that are used will be efficacious, because of the necessity for, I guess you would say, lifelong therapy, although I never like to say that to my patients because I thought that was a very daunting challenge. So I would simply say, for the foreseeable future, we have to ensure that patients have access to medicines that are well tolerated, that have few drug-drug interactions, and that they're going to be able to take for a significant period of time. This slide shows the latest guidelines by a number of the most important ones in many places: IAS, the US DHHS, the European guidelines, and WHO. And it shows the classes, and what I want to emphasize at this point, green is obviously preferred, and you can see that there's a new, relatively new class, the integrase inhibitors, and INSTI, for those of you who aren't aware, this stands for the integrase strand transfer inhibitor, the mechanism by which the current antiretroviral integrase inhibitors work. I think it's also important to point out that one of these has now been placed on the alternative list by the WHO, and there's a lot of reasons for this, and one of these, I'm very proud to say at ViiV Healthcare, is we're trying to make sure that Diotegravir, the latest of the integrase inhibitor, is made available globally to any patient who needs it, and that's why it's placed at this particular time in the alternative category. This slide just briefly shows a comparison between the current integrase inhibitors, Raltegravir that was approved in 2007, Elvitegravir that came out in 2012, and then Dolutegravir, which came out in 2013, just showing some of the similarities, perhaps some of the minor differences between them, advantages, disadvantages. I'm going to talk about Dolutegravir this morning. So let me go over the studies that have underlined the approval of Diotegravir. The data package that was submitted to the regulatory agencies, both the FDA and the EMA, included 3 large treatment-naive trials and 2 smaller but very, very important treatment experience trials. Now, these trials were done before I got to ViiV, so I cannot claim any credit for how these were done, but I do want to point out a few things, and because of time, we're only going to speak about the naive trials. The first one is the single trial, and this compared Diotegravir plus the fixed-dose combination of abacavir and 3-TC with the standard of care ACHA. The second trial that I'll show you the data on was the Spring 2 trial. And this compared Diotegravir with raltegravir, which is generally considered, has been generally considered the best of the so-called third agents. And the last of the antiretroviral naive trials is the Flamingo trial, where Diotegravir was compared to boosted darunavir, generally considered one of the most, if not the most, potent single agents. So let's take a look at the data. I mentioned this is the single trial, and I'm just going to briefly walk you through it. This was a 3-year trial, 96 weeks of blinded, and then an open label phase up to 144 weeks. In treatment-naive patients, there were a number of stratified subgroup analyses that were made at baseline, including stratification by baseline viral load and CD4 count. And as I mentioned, this was Diotegravir plus abacavir 3-TC versus the standard of care. And for simplicity, I'll refer to that as ACHA. This slide shows the virologic response through the 3-year study. I want to point something out first. This is the proportion of patients, viral load less than 50. I want to focus on the first several weeks. What you'll notice here with the Diotegravir arm compared to the ACHA or the efavirenz arm, there is an early and more profound reduction in viral load beginning. Now, this is not just due to the Diotegravir. This is a class effect of integrase inhibitors, and I think from the patient standpoint, the faster you can get the viral load down, the better, not just from a number of clinical reasons, but perhaps from psychological benefit to the patients. Afterwards, the comparator arm catches up. What is the data? At the primary endpoint of 48 weeks, then at 96 and 144 weeks, Diotegravir was shown to be statistically superior than the efavirenz arm by pre-specified analysis. Now, I do want to point out that the statistical superiority in this particular trial was due not to a difference in virologic efficacy, but a difference in significantly fewer discontinuations due to adverse events in the Diotegravir arm compared to the efavirenz or ACHA arm, and we'll talk more about that. It doesn't really make any difference which of the subgroups you take a look at. The response rates were consistently higher in the Diotegravir arm compared to the comparator, efavirenz, whether it's a baseline viral load, baseline CD4 count, gender, or race. Importantly, throughout the study, there was a statistically better increase in CD4 count from initially and all the way through. This slide only shows for 48 weeks, but the data held for 144 weeks. This was very similar to the Start-Merck trial, which also showed some superiority with respect to increases in CD4 count. However, at this particular time, we don't know if that statistically better increase in CD4 count translates into something in the long term which would be better for the patient. This is the Spring 2 study. Again, comparing Diotegravir versus the generally considered best tolerated antiretroviral medication, Raltegravir. And let me walk you through it. This was a randomized placebo-controlled trial comparing once-a-day Diotegravir versus the standard dose of Raltegravir at twice a day, plus investigator-determined background regimen. And generally in our studies, whether it's the Spring 2 or you'll see very shortly the Flamingo trial, investigators will usually choose the combination of tenofovir FTC at about 2/3 to 1/3 or 60% versus 40% compared to the background regimen of abacavir and 3TC. Let's take a look at the data over here. Now, as I pointed out in the previous study with single, where there was a difference early on, you can see this class effect, that both Raltegravir and Diotegravir had a profound early suppression of viral load. Again, I want to emphasize a class effect. At the primary endpoint of 48 weeks, and then again at 96 weeks in this trial, Diotegravir was shown to be non-inferior to Raltegravir with similar increases in CD4 count over the duration of the trial. Let's take a little bit deeper dive here. This shows the pre-specified analysis with baseline viral load and background nuke regimen. Let's take a look. I want to point out that at high viral loads, there was a statistically better response in the Diotegravir arm compared to the Raltegravir arm, 78 and 63. For reasons that are not clear to me at ViiV Healthcare, why we did not talk about this in the publication and why we've not talked about it more often remains a mystery. Well, what about the background regimen? Although there's it appears to be a numerical difference between the use of abacavir 3TC and tenofovir FTC in this trial, only looking at Diotegravir, this difference was not due to any difference in virologic efficacy. This was solely different due to certain other factors like protocol violation, discontinuation for other factors, and in one site, there were some problems there which resulted in having to include all patients as failures in that particular regimen. Let me go on to the third trial, and this is the Flamingo, in which Diotegravir plus the background regimen was compared to darunavir once a day. Again, investigator-determined background regimen. This was also a 96-week trial with the primary analysis at 48 weeks. Let's take a look at the data. This shows the virologic efficacy over the duration of the study. Again, you will see the class effect of how quickly integrase inhibitors can reduce viral load, especially in antiretroviral naive patients, and the comparator will lag behind, but then generally try to catch up. Let me point out some other important factors of this study. At both 48 weeks and at 96 weeks, Diotegravir was shown to be statistically superior to the comparator boosted darunavir. Now, in contrast to the single trial, where the statistical superiority was solely driven by fewer discontinuations due to adverse events in the Diotegravir arm compared to the triple arm, in the Flamingo trial, the differences in statistical superiority were driven by fewer discontinuations due to adverse events in the Diotegravir arm, but also fewer virologic failures in the Diotegravir arm compared to the darunavir arm. Let's take a look at a little deeper dive. Overall, 80% versus 68% at the end of the trial, although there are no statistical evaluations on this particular slide. As I mentioned, this was statistically better, superior response over here. And again, I want to point out at high baseline viral load, the Diotegravir arm was statistically superior to the Darunavir arm. And it made no difference here whether or not the background regimen was abacavir 3-TC or tenofovir FTC. Well, the key here is how well tolerated is Diotegravir and how safe it is. Let me just go over very briefly. I'm just going to summarize the safety data here in the interest of time. In the single trial, much fewer grade 2 to grade 4 adverse events in the Diotegravir arm compared to the ACHA arm. And as I mentioned, 4% discontinuation due to adverse events in the Diotegravir arm versus 14 in the ACHA arm. Well, what about comparing, again, Diotegravir versus the generally considered best tolerated third agent, raltegravir? And here, the number of adverse events were exactly the same in both and very low, and there was only a 2% discontinuation rate due to adverse events in both of these arms. I guess testing to the extremely well tolerated integrase inhibitors, raltegravir and Diotegravir. What about in the Flamingo trial? Again, I mentioned fewer discontinuations due to adverse events in the Diotegravir arm compared to the Darunavir arm, although discontinuations due to AEs in both was very low. The main difference here, not unexpectedly, had to do with some lower rates of diarrhea in the Diotegravir arm compared to the Darunavir arm. I do want to point out an important factor about Diotegravir, which we've seen over the last couple of years in some other of the more recent antiretrovirals, especially in the integrase class, and that is initially there is a small rise in serum creatinine which does not affect renal function. And the small rise in serum creatinine simply has to do with one of the effects of Diotegravir on one of the renal transporters in the proximal convoluted tubule, blocking the organic cation transporter 2, resulting in this small increase in serum creatinine. Important to note, however, that this increase is small and will not continue to increase with continued use of Diotegravir. And at the bottom of the slide, it simply shows the usual ways of evaluating renal function in the clinic. There were no changes. And we also have done actual measurements of renal function showing that there's absolutely no effect. So if you have access to Diotegravir, you're going to see this small increase in serum creatinine. It should not continue to increase. And if it does after 4 weeks, then it's time to look for other factors affecting increases in serum creatinine. It's also been joked somewhat internally that the small increase in serum creatinine with the use of Diotegravir may actually be a marker of adherence to the particular medication. Is Diotegravir convenient to take? I already mentioned that in this day and age, convenience is a very, very important aspect of offering the best antiretroviral medications to our patients. I'm just going to basically summarize this in terms of the attributes. Like raltegravir, Diotegravir does not require any boosting by a pharmacokinetic enhancer. As a result, not only of the fact that a booster is not required, but also because of the general physical and chemical structures of Diotegravir, there are few drug-drug interactions with commonly used medications. Also, very importantly, you can take Diotegravir any time of day. It doesn't make any difference whether there's food or not, so the patient has the flexibility, and the pill size is very small, which is very, very important for many, many people. No drug is perfect, and Diotegravir is certainly not perfect, although we feel it has many of the attributes of being one of the best single antiretrovirals to ever come out. There's no dose adjustment used with many commonly used medications. There are, however, some dose adjustments. For example, if you have co-infection with tuberculosis and you choose to use Diotegravir, you must increase the dose of Diotegravir to 50 milligrams twice a day during the treatment for tuberculosis. And we have some ongoing studies just to show from a safety standpoint there's no problem. Like Raltegravir, there's also some separation that's necessary if you use certain types of antacids or certain cation multivitamins, for example. And there are some dose adjustments if you're going to use with efavirenz, nevirapine, boosted topranavir, or atrovirine, but the chances of using Diotegravir with most of these is really not of any consequence. And I want to basically conclude to talk about the barrier to resistance. And although we don't have time to talk about this, to me, the barrier to resistance of an antiretroviral medication is very misunderstood because it is not the same thing as the genetic barrier to resistance. The genetic barrier to resistance is only one of several components that comprise a barrier to resistance of an antiretroviral medication or to, more importantly, an entire regimen. I'm going to walk you through this, and I think it's important. This is a summary of what happens in the 3 naive trials that I just showed you in patients who fail. Now, there's a couple things I want to point out. This is the single trial versus ACHA. This is the Spring 2 trial versus Raltegravir. And this is the Flamingo trial versus darunavir. First of all, you'll notice that in both arms, the number of protocol-defined virologic failures is very small. However, when you fail, there is a price to be paid depending on the regimen you're on. What do I mean by that? Let's start again in the middle with the single. Equal numbers of subjects with protocol-defined virologic failure. If you fail in the ACHA arm, what happens? Not unexpectedly, you will develop a number of resistance-associated mutations to the non-nucleoside class. But you may also, at least in this case, and in this particular study, there was an associated, important resistance-associated mutation to tenofovir, the K65R, which in naive patients is very difficult to develop, but at least in this trial, it happened. Now, what about the Diotegravir arm? If you failed, 2 important things. Number 1, there was no development of any integrase-resistant mutations, and perhaps just as important, there were no mutations associated to the background regimen. Well, from a clinical application standpoint, what does that mean? You might be able to talk to the patient about adherence and put the patient back on the same regimen because there's no resistance developed to any of the regimens, any of the components of the regimen. What about Spring 2 with Diotegravir versus Raltegravir? Similar number of patients with protocol-defined virologic failure, but what happens? In the Raltegravir arm, if you failed, you will develop some, although very few, some resistance-associated mutations to the integrase class. Similar to what we saw with the single trial, you will also develop some resistance-associated mutations to the background regimen, meaning in that particular regimen, it limits the ability to use other ARVs in the regimen. Let's take a look at Diotegravir. Again, if you fail, and I want to emphasize this is only in antiretroviral naive patients, not only will there be no integrase-resistant mutations, but once again, we see no mutations associated with loss of susceptibility to the background regimen. And lastly, let's talk about Flamingo. We all know that the boosted protease inhibitors have a high barrier to resistance, or particularly a high genetic barrier. What happens in the darunavir arm when you failed? As what we've seen before, although the number of protocol-defined virologic failures were small, if you did fail, there were no protease-associated mutations and no mutations associated with the background regimen. Let's take a look at what happened with Diotegravir. As we saw both against efavirenz and raltegravir in the Diotegravir arm, when you failed, no mutations associated with resistance to the integrase class and no mutations associated with the background regimen. Let me summarize the overall results that we've had, and I've not had time to show you this, but I think it's important just to point out that a number of in vitro studies and looking at exactly why Diotegravir differs from the other two integrase inhibitors suggest that it does have a high barrier to resistance. I just talked that in treatment-naive patients, to this time in our clinical trials, no evidence of any treatment-emergent mutations to Diotegravir has been seen. Although I didn't have time in treatment-experienced integrase inhibitor-naive subjects, the development of resistance was lower with Diotegravir than with raltegravir. And when resistance-associated mutations occurred, there really was not any change in susceptibility to Diotegravir. In treatment-experienced, and this is the highly treatment-experienced patients, who had also had developed documented resistance to the other two integrase inhibitors, it required a number of particular integrase-associated mutations in order for there to be decreased susceptibility to Diotegravir. I think importantly, there's been no in vivo evidence of emergence of any significant novel mutations that result in a substantial increase in Diotegravir susceptibility. There's some ongoing work in highly treatment-experienced patients to that regard, but for purposes of what I'm talking about today, and that is when we start a regimen in the naive segment, this is what we're seeing. And although I didn't have time, one of the mechanisms that we believe underlies, again, the difference between Diotegravir and the other integrase inhibitors is a slow dissociation from Diotegravir, from the enzyme DNA complex, and the need to have multiple mutations in order for loss of susceptibility to Diotegravir to occur. In summary then, the attributes of Diotegravir include a once-daily administration without the necessity for a pharmacokinetic enhancer, low PK variability, it's well-defined, a low potential for drug-drug interactions, although not perfect, there are very, very few, like raltegravir, generally well-tolerated, doesn't make any difference what time of day, with or without food. This distinct in vitro resistance profile with an apparent high barrier to resistance is perhaps one of the most important attributes of Diotegravir, and it is highly potent antiretroviral activity as evidenced by both the, especially the Spring 2 trial and the Flamingo trial in high viral loads. And lastly, let me just summarize where we are. HIV treatment guidelines and regimens have evolved considerably to the benefit of the patient over the last 20 years especially. We still face many challenges. You will still do that, especially for the necessity of taking antiretroviral therapy for the foreseeable future. I started out by saying as a result, and if patients can get linked to care, stay in care, stay on the antiretroviral medications, they will do extremely well. Diotegravir is now recommended as part of the initial treatment regimen in a number of the important international guidelines. The use of Diotegravir is supported by a number of extensive clinical studies. It's demonstrated a high barrier to resistance, and it's suitable for pretty much any patient should you feel that dolutegravir is warranted in your particular patient population. Shay Shay.